Hello, everybody. I am Dr. G.N Ramesh. I am a medical gastroenterologist and a lead consultant in medical gastroenterology at Aster Medcity Kochi. The fourth pillar is the endoscopic therapy or the endoluminal therapy. Now, this is something that is now coming up in a big way because endoscopic access and refining of technology has resulted in our ability to either fix the gastroesophageal junction wherever it is loose or ablate the Barrett's esophagus if it is there. There is yet another technique which is called mucosal excision and suturing, otherwise known as ARM, or even simply injecting an agent into the submucosal region at the G junction, which will cause constriction. These are various principles around which endoscopic therapy for GERD revolves around. But for your knowledge, I think I would just like to say that we have now endoscopic suturing devices or the mucosal excision technology. These are the two technologies or techniques that are commonly being used. This is a process in evolution. The experience available is not all that widespread, but the results are good. And the most important thing is it avoids surgery. So therefore, in conclusion, I would like to say that gastroesophageal reflux disorder is a very, very common problem. It can present either with a classical presentation or with atypical presentations. The management revolves around lifestyle modifications. And this is something which is so very important that it should be the first thing that we advise our patients with GERD. The second pillar, of course, is the medications. And in the medications, it is the proton pump inhibitors that are most important. We can start with once daily, increase it to twice daily, double the dose, switch between PPIs, all in an effort to get control over the symptoms. Other agents that reduce the acidity like antacids and H2 receptor antagonists are all only for secondary use. A patient who does not respond to all this, both of these pillars, is termed refractory GERD. And for refractory GERD, we need to do an endoscopy. And if the endoscopy is normal or plus minus findings, we may have to send the patient for a 24-hour pH study. Surgical therapy needs to be reserved only for a small segment, but before subjecting the patient to surgery, we need to do a manometry to ensure that the esophageal contractions and peristalsis are normal. Endoscopic therapy is coming up in a big way. The evidence for it is accumulating, and very soon we will have much more to say about endoscopic therapies. But having said that, I would just like to leave you with one basic message. Whatever technology has to offer to us, the most important thing is our clinical sense. And we must use our clinical sense to find out whether the patient actually has acid reflux or not. Use technology only to support our diagnosis and not go by technology alone. In this way, I think we will be doing great justice to our patients with gastroesophageal reflux disorder. Thank you very much.